Hi, everyone. My name is Dr. Rachel Giles, and I am the chairman of the board of the International Kidney Cancer Coalition, better known as the IKCC. And we are actually a federation of nearly 50 organizations scattered throughout the world that serve kidney cancer patients and try and provide them with information and the tools they need to navigate a kidney cancer diagnosis and treatment landscape. So I'm pleased to be here. Thank you for inviting us. And I'd like to pass the mic over to Professor von Amsberg.
Thank you very much, and hello from my side as well. I'm Gunhild von Amsberg. I'm working at the University Hospital of Hamburg-Eppendorf and have been concentrating on urogenital malignancies for the past years with a special focus on clinical trials and especially kidney cancer. So I'll hand over to Stephen.
Thank you, Gunhild. My name is Stephen Hildemann. I'm Chief Medical Officer at Ipsen, where we focus heavily on rare diseases, the neurosciences, and our main focus, oncology. I'm an internist by training and an active professor of medicine with some residual practice and clinical training. It's an absolute pleasure to be here with both of you today, and our mission is an important one. We're going to, in the next few minutes, dive into the clinical, patient-centric, and industry perspectives of people living with kidney cancer.
All right, so I guess we should be setting the scene here for what we're going to be talking about today. And I think I'll talk about briefly the burden and the impact of kidney cancer. And I think we should start with what we know about people living with kidney cancer today, because I think that's a great place to start from my point of view. Cancers of the kidney are actually one of the more common types of cancer. In many countries, it's in the top 7. I think globally it's the top 14th cancer. And there's about 400,000 new cases diagnosed each year. And of those, the renal cell carcinoma, usually called RCC in the field, is the most common type, accounting for approximately 90% of all cases. If detected early, the 5-year survival rate for kidney cancer is not bad at all. It's quite high. But for people living with metastatic kidney cancer, the 5-year survival rate is only about 12%. So there's lots of room for improvement there. But having said that, there's no doubt that people living with kidney cancer have more options available today than they've ever had before. And the last 15 years has really seen a huge change in the treatment landscape. But despite this shift towards a very advanced approach to treating kidney cancer, there's still a long ways to go. And particularly for people living with advanced kidney cancer, but also people with localized disease who live with a fear of recurrence.
No, thank you very much, Rachel. And you've highlighted a number of, key factors in, why not only does kidney cancer have an enormous burden of disease worldwide, but you've also, highlighted the recent cause for optimism that we've seen with trial readouts over the past years, which have changed the landscape dramatically, which have added much life to even patients with advanced kidney cancer. And with, virtue of combination therapy, I think now offers many new options to really look at different aspects rather than just the efficacy, but really the balance between benefit and risk of these treatments, which in the end translate to quality of life. So that would be one of my comments to your introduction, Rachel, but back to you.
Yeah, I think living with kidney cancer, it's like many other cancers, it's very overwhelming, it's stressful. It causes a lot of, psychosocial impact on the individual patient. And the impact is so unique to every single patient. But however, the difference between kidney cancer and, say, other cancers is that with kidney cancer, almost all patients are diagnosed asymptomatically. So that means that they've gone to the clinic perhaps for another screening with another issue, perhaps a cough or something, and their kidneys get scanned and they go home with a different diagnosis than they'd ever thought they would have. And also the kidneys are not really very understood in the general population. The average person doesn't really even know where their kidneys are or exactly what they do. It's not exactly an organ that has a public image like perhaps breasts or other things that people do know what breast cancer is. But kidney cancer kind of hits people over the head. They've probably never met another person with that disease, but they probably don't know anything about it or what it might mean. So they're suddenly, faced with understanding this huge amount of information and understanding what it means for them and values and approaches to that decision, the set of decisions that they have to make fairly rapidly. And it's quite hard for the patient to experience at that point to deal with that. And the partners, of course, too, are taking on that. So we ran a global patient survey in 2018 and again in 2020, and we saw that about 96 or 98% of the patients do declare having a major psychosocial impact on their life due to their kidney cancer diagnosis, which is not surprising. I mean, you're diagnosed with cancer, it's going to impact your life. What was surprising of those individuals actually talk to anyone about it, their partner, their healthcare professionals, a nurse, anything. And that is something that we feel is quite actionable to try and raise that discussion. And that was actually the theme of our World Kidney Cancer Day the last 2 years. One was about, we need to talk about how you're feeling. And the other thing that's really important is to note is that the COVID-19 pandemic has really exacerbated these issues, and loneliness has crept into the whole equation. Not knowing how to navigate the system, especially when the system doesn't really know itself what it's doing in the crisis of the pandemic. And it's really hard to understand, the breadth and depth of how people are feeling in these circumstances as well. So as part of the World Kidney Cancer Day 2021 this year, like I mentioned before, we had the theme, we need to talk about how we're feeling. We had a personalized psychosocial well-being report that was generated for over 7,000 patients. And this gave tips and tricks run by a psychologist to help you, the individual's well-being. And it's so important to have a patient who feels in control of their disease situation and the options that they have, because we know that can actually translate to even hard clinical outcomes, such as improved survival.
Yeah, I mean, there's so many points you already made and Stephen already made. I think the treatment landscape also being for us clinicians has totally changed. And there now we move from this very great, like having acute diseases to a more chronic course of disease. So that's really a great position for the patient, but also for the physician. And now suddenly other topics, as you just mentioned, move more into our focus of everyday's treatment. We have questions that need to be addressed on how we can bring people back in everyday's work and everyday's life. They ask questions like, how can I integrate my disease treatment into my job, into taking care of children, or into even planning a vacation? I think this is really something which we wouldn't have dared to ask years ago. So actually, within this context, as you just mentioned, quality of life really moves very much into the focus, not only of clinical trials, but also in our everyday's dealing with the patients.
No, thank you, Gunhild. And this has been an interesting theme at ESMO last year in 2020 at the European Society of Clinical Oncology, but also this year at a major cancer congress, that the field seems to be moving, just as you described. We have novel clinical study readouts where quality of life is systematically measured in an organ-specific way, so in a way that focuses on the kidneys themselves, but then also related to the entire patient's quality of life, just as you've described. But interestingly, I was made aware of a publication by you, Rachel, that surfaced last year, where in a survey of 21 clinical trials over the past decade, only little more than half systematically measured quality of life endpoints in clinical trials. So, given what we've heard from both of you, I think this is a call to action for all of us doing clinical trials, for designing clinical trials in industry, for example, that we make it a consistent habit to introduce deep patient-related outcome measurements, that we put the right metrics into our scientific questions and asks, so that we actually measure and precisely quantify quality of life to patients, because initial literature readouts tell us that quality of life may connect to a positive prognosis in cancer, let alone a better quality of life for patients and their families.
Yes, and I think we should add one trial, actually, Rachel and I were discussing a few weeks ago, which was presented at ASCO 2017, where actually PROs were continuously monitored in one group of patients, while another group of patients actually just received the regular treatment, seeing their physician, but not reporting their cancer-related issues in between. And what they found out is not that they only can improve the quality of life of those patients by around 30%, but also decreasing the times patients had to present to the emergency room. And surprisingly to me was that they even improved overall survival with as much as 5 months. And I think if that would have been a drug, I think that would have been a real blockbuster. And it was in the plenary session emphasizing that really quality of life now moves into the focus, not only, of course, of the patients, and I'd love Rachel to comment on that in a moment, but also in our physician's point of view. So, Rachel, how would you see this?
Yeah, survivorship is actually bringing these new considerations for the kidney cancer community, and it's a luxurious situation that patients have and the patient community has never really been exposed to previously. So, living longer, the concerns just aren't about the treatments themselves. And certainly we've mentioned this before, that the treatment landscape has changed so much, but actually we want to know, what is life like during treatment and what is the life like after treatment, because that is as important as the treatment itself, in our opinion. So there are, for example, concerns about long-term effects of immuno-oncology agents, or also other agents such as that may affect cardiovascular health going forward. And we just don't know the answers to those questions. And so as the IKCC, one of our kind of dogmas is to try and make people ask those tough questions and call for people to measure those important outcomes. And quality of life is certainly an outcome that should be considered always as a key secondary endpoint, in our opinion. And it's actually quite scandalous that trials in the modern days are not collecting that data, because the choices that the patients are becoming more and more informed with time, and they need to have that information available to them to make the right choice. So anyway, we just want to say that each individual is affected by their disease in their own way, and we can't make a decision for everyone about this. It should be presented as a choice, a discussion together with the patients and their partners, and understand what are the individual components that may detail a personalized plan for that patient.
So really, this is a strategic partnership, honestly, between industry, the clinicians, patient organizations, and representatives. And honestly, it's a deeply meaningful challenge and task for us here at Ipsen. We've, in my organization, the medical organization, started a fully dedicated group collecting data and insights on patient-related outcomes around patient centricity. So we're heavily investing in this field, and it's one of the things that will be central to us going forward in our clinical research, not just in kidney cancer, but in other cancers and rare diseases as well.
So I had a question for Professor von Amsberg about the patient-reported outcomes. Can you speak to that? What's important in determining how those PROs should be developed, and which PROs are the most effective in gathering that data?
Well, from a physician's point of view, I think just to meet all the patients' demands, we really need to address the questions in the patient's way. So with the time, I think, and this probably even better than I do, the patient's influence on developing the PROs has been increasing actually. And I think here we really need to make changes maybe according to the new developments, because we've been integrating, for example, checkpoint inhibitors now on a regular basis, but the old instruments have been developed the years before, so maybe there's some issues which need to address and adapted. And on the other hand, of course, we really need to face time moving. So we have electronic devices which have not been integrated in the way they probably could and make life easier and just speed up the communication between the center, the nurses, the doctors, and the patients, just to integrate patients' issues very fast and react very fast on the same day or within the same hour, even if possible.
So, the clinical trial mandate is really one that we, can solve and will solve. I'm really quite optimistic there. We've seen major developments in the field just over the course of the last year. We actually measured with many of our colleagues in discussions with, leading clinicians yourself, that the value that leaders and experts in the field assign to quality of life has changed dramatically, even within a short year. 1 year ago, it quite frankly wasn't, all that high across the world, and, was ranked differently in different areas of the world, to our surprise. But asking the exact same question on quality of life, does it matter? What is the impact? 1 year later, we've seen a dramatic shift in the scientific community, at least in the top. What I think about, Rachel and Gunhild is, yes, we may have this consensus, in the top experts and leaders, the data is on the table, the data, we know the data. How do we now really, educate our colleagues, our physicians worldwide, to spread the information and to make sure that this important development, reaches the field consistently across geographies, right? I think that's a task for academic medicine, for sure. But it's also a task for your organization, Rachel, and for ours.
Yeah, I think a two-pronged approach is really called for here, bottom up and up and top down. So trying to work with the physicians to get them to understand and trickle down the information, but it's really important to inform the patients too, so that they can go to their medical team with this information and say, how can this apply to me and my situation? And is there something here that I can, apply and implement into my caregiving at this point? So it's an important discussion to have.
I would only agree. I think we need really improved education, not only of our patients, but also of the physicians around the world, because I think some of my colleagues may have not understand that the luxury situation Rachel just mentioned before, that we really need to bring the patient's focus into the center of treatment and really make individualized decisions based on the situations the patients are in the course of the disease, but also in the course of life, because one treatment may be the best one for one patient, but not the optimal for the other. And I think shared decision-making and quality of life integration is really an important point to make in this context.
I think that was a near perfect summary. This has been a delightful conversation on a very critical topic that I know will keep all of us busy, not just for this year, but for many years to come. I've been privileged to speak to you, Professor von Amsberg, and to you, Dr. Rachel Giles. It's been a pleasure, and you can count on our commitment to continuously drive the science, design the clinical trials in the right way, keep close contact with the patient community, which we will involve in every step of our program and science process, from the design of clinical trial studies to the approval, the life cycle management of new indications, and of course to the academic communities and our top colleagues in the field that at the end of the day will be our beacons to spread the knowledge and to educate not just their physicians and your junior staff around you, but the rest of the field as well. So thank you both very much, and it's been a pleasure and a privilege on behalf of patients living with kidney cancer.